We talk about PKPD, MIC, Cmax, and AUC and how they determine the characters of an antibiotic. MIC or minimal inhibitory concentration is a standard way of predicting drug sensitivity. That's what you get on your culture reports. It assumes the drug will reach a certain concentration in the infected area. So the MIC of a particular drug is dependent on that. And every drug has a different MIC level assigned to it. Now, when we look at the concentration of a drug, we have three things to look at. The P peak, or the peak levels which the drug reaches, is called the Cmax. The AUC, the area under the curve, the average drug concentration which remains over a period of time, and that period of time is another parameter that we need to look at, and that is the duration of action of the antibiotic. Now, some drugs are dependent on peak concentrations and others on AUC. So from this we can infer that some drugs are better when we give high dose less frequently, like aminoglycoside once a day, and others which we should give over a prolonged period of time more frequently, like the carbapenems. And to know what period of time was the drug effective, we need to look at the action duration of the drug, and ideally we would like to be 100% of the time the drug fulfills that, but that seldom happens. 50 to 100% of the time is what we would like to see. If you look at how much Cmax we desire, it is 8 to 10 times of the MIC, and for AUC it has to be 4 to 5 times ever MIC. Now, how can we strategize based on this information? Now, as we said, one dose daily for those which are dependent on peak levels and high dose prolonged infusions. So now we have come to a point where we are using carbapenems as a 3-hour infusion, 6 to 8 hourly. And we can also consider combination agents when the MICs are high. Therapeutic drug monitoring assumes a lot of importance. We have given mainly vancomycin and aminoglycosides that right in our practice, and mainly because of toxicity issues rather than efficacy. But we are used to doing therapeutic drug monitoring for vancomycin and aminoglycosides. There also, we might be interested in the peak levels like in aminoglycosides, but in vancomycin, it's actually the AUC which we are interested in. So you see, these two drugs that we are doing therapeutic drug monitoring for, they have different parameters to be looked at. Now, what happens to these parameters in sepsis? In sepsis, the volume of distribution, which is VD of the drug, increases because there is increased capillary leakiness. And there is alteration in protein binding also. Albumin levels fall, which is one of the major plasma proteins and one of the major proteins to which drugs bind. And the alpha glycoprotein levels increase. They are very small in amount. So in normal circumstances, they do not bind as many drugs, but it's a positive acute phase reactant increases significantly and starts to bind basic drugs. And then there is a change in metabolism and clearance also because of hepatic and renal dysfunction, both of which can coexist, and actually both of which can affect the function of the other. And then there are also extracorporeal therapy, renal replacement therapy, which can go on for 24 hours, and then ECMO. The drugs may have a lot of clearances, and add to these the presence of defects in metabolism, inherent ones like presence of liver and kidney disease. It becomes very complex. So you should have therapeutic drug monitoring probably as a part of your management when you have these tricky situations. One way of knowing how to dose our drugs in sepsis could be to look at the antibiotics as hydrophobic and hydrophilic. So hydrophilic are very soluble, but they do not concentrate as much intracellular because they cannot cross the cell membrane, and their distribution increases significantly in sepsis. So the volume of distribution of hydrophilic drugs is much higher in sepsis. And the classical example of these are beta-lactam drugs. So you generally tend to dose on the higher side. The beta-lactams, including carbapenems, are hydrophilic. In general, drugs with large therapeutic window should be dosed adequately the first 2 to 3 days. So beta-lactams have a large therapeutic window, unlike aminoglycosides, which you cross a particular serum levels and you have toxicity manifesting. And thus we have also changed over now to using high dose prolonged infusion drugs when we are dealing with drug resistant bugs or bugs with very high MIC cutoffs. The recommendations of change of the drug as per the GFR is more applicable to chronic kidney disease, where there is more stable renal function. In sepsis, not only is that altered metabolism of the drug because of altered protein binding, leakiness, distribution, metabolism, but also because the renal dysfunction is also very dynamic. Patients might recover over a few days, regain function, they may have a stage of hyperfiltration as well. So, if you have a drug with a large therapeutic window, use it adequately for the first 2 days, 3 days, and then by then you have the culture reports, you know the MICs, you know are you dealing with a drug resistant bug, and then you may make a choice of whether you want to continue with that the same dosing pattern, you want to do therapeutic drug monitoring. But we need to understand that to optimize our antibiotics, especially in the situation of drug resistant bugs, we need to dose them correctly.